Good morning, everyone. So I am going to start. My name is Dr. Jessica Gray. I'm on the board of MASAM and thrilled with the opportunity to start us off today. It's earlier minutes in a while. All right. We are so thrilled to start the virtual portion of our MASAM's Methadone in the Modern Era series. So this is sort of a continuation of the Pearls for Practice that we had last fall, and we hope to see many of you next fall for ongoing. But so today we are thrilled to have Dr. Zervos here for session 1, Methadone and the QT Conundrum. And we are grateful to be co-sponsored by Graykin Center and BSAS, so we thank them for their ongoing support. So I am here to introduce Dr. Zervos. He is an assistant professor of medicine in the MGH cardiology division at Harvard Medical School. In terms of a brief bio, although there's a lot more than this, he finished cardiology training at MGH. He's a staff clinical cardiologist still at MGH with an interest in non-invasive myocardial perfusion imaging, including PET-CT. He has had many years on the cardiology inpatient teaching service for residents, fellows, and I would add faculty and others alike. And so we are really thrilled to have his expertise today. Just a couple of sort of ground rules for the morning and logistics. We would love to know who's here. So if you feel comfortable, type your name, where you're coming from, and your role in the chat box. Please, if you want to turn on your video, not if you're driving, but we'd love to see who's here. Remember to mute your mic when you're not speaking. We are going to have time for questions at the end. So when you do speak, please share again who you are and where you're coming from. Thank you, Michael, for demonstrating. And you are now registered. So this is all set. And we don't have accreditation for this setting for CME. So just enjoy it and all the learning that you're going to get in this hour with us. So just in terms of what's ahead, we have session 2 of this virtual session with myself and Dr. Megan Miller. We'll be diving into methadone and pregnancy, and that'll be April 11th, also at the bright and early time of 7 a.m. And then please save the date for the fall Pearls for Practice. That's going to be at MMS, Mass Medical Society, on September 13th and 14th of this year. And finally, we just want to remind everyone that we introduced the Dr. Barbara Herbert Award last Pearls for Practice, which honors our beloved colleague and friend, Dr. Herbert, and planned for the second annual award will be this fall, but we would be grateful for any donations for folks who feel impacted by the amazing work that she's did in her lifetime. So there's a link if you want to donate to that award. And without further ado, I hope that everyone gets a lot of learning today as we really think about methadone and the biggest cardiology question I think out there, right? Which is what we do about the QT. And so thank you, Dr. Zervos, for being an expert to talk this through with us.
Sure. Let me see. Let's see if I can share my screen. Can everybody see this?
Perfect. Yep. Looks great.
Okay, shall we start? So I guess today is a leap day, or happy leap day to everyone. So by some configuration of improbabilities, have lived at the intersection of cardiology and addiction medicine. A very good friend of mine who was a hospitalist at Mass General introduced me to his brother, who was running a CSAC situation, and in 2015 I started working part-time there. So let me move right along to this issue that we all deal with, that we all face, that is an ongoing conundrum for all of us. Disclosures, none relevant to this presentation. So, in treating patients with methadone, we all encounter ECG and QT dilemmas. And as a clinical cardiologist who believes addiction services are critically important to society, the following discussion aims to remind us in a very general way about methadone and QT issues, always looking to avoid reliance on formulaic solutions. So the conundrum is this. Without getting into the exotica of electrophysiology, we all know that methadone prolongs the QT interval. And we all know that a prolonged QT interval on the electrocardiogram can theoretically cause a fatal arrhythmia. But methadone, we know, prevents fatal overdoses. And how do we assess that relative risk? Torsade-related VT, VF, and sudden cardiac death is not easy to diagnose after the fact. It is not a post-mortem diagnosis. And if you look at the studies that they've done, it's presumptive. It's sort of you rule everything else out, and you're left with a blank sheet of presumptive arrhythmic death because there's no hard data, there's usually no toxicology, it's just there because most people who have sudden cardiac death aren't connected to telemetry. On the other hand, if we're assessing risk, overdose and death is more easily quantifiable because it's just self-evident. So those two risks. And, you know, again, this talk is about looking at these competing risks, trying to use methadone in the way that we know has improved society while minimizing the risks of these theoretically, potentially fatal methadone-related cardiac arrhythmias. And we all know this is always an individualized decision. And in this setting of uncertainty and risk, I was looking for a way to incorporate this last sentence. You know, whenever we're looking at these competing risks, whenever we're looking at the risk of something happening on the electrocardiogram versus an up titration of methadone, I always try to incorporate the clinical rationale for methadone dosing inside the syntax and sentence of an actual order for a patient. Dan Greer, who is, he's a senior vice president at Baymark, has been kind enough to sort of let me work on my own schedule at the Baymark Clinic in Peabody. So I still write orders and I still see patients. So what is a prolonged QT interval? You can see on the left a normal ECG. You can see on the right a long QT. The QT interval reflects repolarization of the ventricle. The longer this, how can I put this metaphorically? The longer this period between the QRS and the end of the T wave, leaves more room for electrophysiological mischief. Things called early after depolarizations. You prolong that period, stuff happens. Electrical signals sometimes pop up out of nowhere and provoke an arrhythmia. Again, that's the metaphor. So that arrhythmia, the dangerous, worrisome arrhythmia, is called torsade, twisting of the points, polymorphic ventricular tachycardia. It is a ventricular tachycardia that can lead to ventricular fibrillation and cardiac arrest. I think if you ask 5 different electrophysiologists how frequently does torsade degenerate into ventricular fibrillation and cardiac arrest, you'll get 5 different answers. My sense, after 30 years on the inpatient wards at Mass General, my general sense of this is maybe 20%. I mean, again, not all, the point is not all torsade leads to cardiac arrest. But I'm sure this is a point of some debate. How do we measure the QT interval objectively? If you have calipers and an electrocardiogram and a calculator, you can do it yourself. Or if you have calipers and a laptop, you can go to a site where you can type in the numbers and it can give you a number off of the screen. It takes a little work. I don't know of anybody that takes out their calipers and a calculator, but we'll get to that in a second. So what is a normal QTC? Again, scanning through the literature, 5 different textbooks will give you 5 different numbers. Boiling this down, distilling this, my best distillation is in females, you can think of a landmark number of 480 milliseconds. That's prolonged. Below that, 460 to 479, I guess that's considered borderline. And in males, a little bit less, anything over 470 milliseconds is considered prolonged. And you can see the range of 460 to 469 borderline. And again, that landmark number, greater than or equal to 500 milliseconds, is generally accepted as a threshold when the risk of torsade is thought to increase substantially. And that, that's, an article of faith over the decades, 500 milliseconds. How close it brings someone to actual torsade in the real world is highly variable, patient specific. So what are the frequently encountered issues that you and I and all of us have when we see patients in the clinic? Screening ECGs prior to starting methadone, and we'll get into these in a minute. Clinically indicated ECGs after starting methadone. And then a huge bump in the road, increasing or decreasing methadone in the setting of a prolonged QT and active use. How do we solve that? How do we solve that problem? So screening ECGs, and this is sort of common sense. Prior to starting methadone, known structural heart disease, or a history that's clearly suggestive of structural heart disease. Not, everyone, can make some comment of, I get short of breath, I did this, I felt lightheaded when I stood up quickly. some clearly suggestive history of structural heart disease. The concurrent use of QT prolonging drugs. I don't know the solution to this. It's an ongoing confounding issue. It requires individual assessment. Some people will come to you with 3 or 4 potentially QT prolonging medications. How to unscramble that is ongoing confounding issue. There is no algorithm or template that will solve that for us automatically. It requires an integrative kind of sensibility about the patient. You know, if you try to get an ECG on someone and everyone who comes in on Seroquel, and you know they're waiting to get their dosing up titrated, and you're waiting for their EKG, in my humble opinion, that's not going to work. Now, a history of sudden death in a first-degree relative should perk up your attention, but again, that history has to be taken accurately. If you ask a lot of folks, you know, somebody suddenly died, you know, many people will say yes, but the situation that provoked that has to be sudden death without a clear mechanism of heart attack, stroke, or the usual stuff. We won't run into familial long QT syndrome very often, but if there is a defined, verified history of long QT, that's where the methadone situation stops and you do need a cardiology consult. That's not a situation where you want to start methadone. But again, I've never seen a patient with familial long QT syndrome in the methadone clinic. And obviously, can screening impede care? We all probably know the answer to that. Excessive screening or you know, if you can screen without slowing down your treatment, that's great. So that was before. How about after? What do we do after methadone started? If we get a history of syncope, all these standard things are common sense, common general internal medicine things, real syncope, near syncope, palpitations, but you know, I mean, I get palpitations. I had palpitations this morning when I couldn't link to the Zoom. Seizure, known chronic metabolic disturbances, hypokalemia, chest discomfort, all of the usual stuff that worries us as general physicians. Well, these often will need evaluation in an emergency room setting. But again, also needed is a detailed history so that upward titration of methadone is not unnecessarily slowed, particularly during the early ramp-up of new actively using patients. We can just find a lot of diversions along the road, and one of those diversions is this QT issue, which, you know, we have to take seriously, but put it in a bigger context. So let's get, what is the dosing threshold for screening ECGs? I guess everyone has their own kind of clinical sensibility about this, but we should remind ourselves that the relationship between methadone dose and QT prolongation is not linear. It's unpredictable and often patient-specific. Again, I've been attending on the arrhythmia service or the arrhythmia floor at Mass General for decades. This applies to other medications too that are QT prolonging, amiodarone, dofetilide, a whole list of medications where you expect QT prolongation, but you can't really predict the magnitude. Moving along, once you get your QT prolongation, the relationship between QT prolongation and torsade is not linear and is unpredictable. And overall, torsade is a relatively rare event in this setting. Again, I don't often see torsade on the inpatient service where we will have 30 or 40 patients on continuous telemetry with active arrhythmia issues. Moving along, QT prolongation in and of itself as a separate entity is not a robust predictor of sudden cardiac death. This is from my Framingham heart study in 2012 with lots of patients over a long span of time. QT interval association and sudden cardiac death are no longer significant after adjustment for cardiac risk factors. So moving along to the dosing threshold for screening ECGs, everyone has their own sensibility about this, and I think we always have to follow our own personal sense of what to do here. Some guidelines suggest routine ECG screening at 120 milligrams of methadone daily. Maybe that was a SAMHSA recommendation at some point in the vague and distant past. I've seen 150 milligrams from Canada. There's no high quality evidence for any threshold. If someone can find it, I'd love to see it. So again, there's the real world logistical and resource issues in our clinics. Not all outpatient methadone clinics have the resources and staffing to acquire ECGs. In the inpatient setting, you can get as many as you like, but not in the outpatient setting. It's obvious. So what about interpreting ECGs in the outpatient methadone clinic setting? It's obviously it's challenging for anyone, but it can be challenging in the clinic setting. Should providers rely on a machine algorithm or hand calculate the QTC using an online tool? Should clinic providers wait for outside formal reads? When I first started at what is now Baymark, as a cardiologist, I wasn't really allowed to interpret ECGs because of some medical legal issue. And we would send ECGs out to be read by internists who would then read the ECG and send it back to us, which again, it slows treatment down. So what if there are other abnormalities? In the ECGs that come to us and we're prescribing methadone, what if we suddenly run into somebody with de novo atrial fibrillation or conduction disturbances or other arrhythmias? What if the ECG is of poor quality or technically limited so that a machine calculation is unreliable? And I'll show you some examples of that. And again, logistical and resource issues, always logistical and resource issues. How do we up titrate in a timely manner that addresses the urgent need at hand, and how do we keep ourselves from getting distracted from that? So, and we know many patients in the outpatient clinic setting don't have timely access to medical providers. Getting an ECG from a PCP could take days or weeks. Getting a cardiology consult can take months. And how long do you wait before making a dosing decision for a patient who is actively using? And what about posing the question, what about a high quality ECG that shows a QTC of 500 milliseconds in a patient who's actively using? What is the answer to that? I can show you some examples of QT prolongation. This is an anonymized tracing from a patient that was on my service. It's not, again, immediately evident to the eye. Sometimes you want to get a sense of whether the QT interval, whether the T wave offset is more than 50% of the R to R interval. Again, that sometimes works if you want to take a glance at it. The machine calculates 569 milliseconds. So after treatment, I forget what we did. We fixed their electrolytes or something. We saw a distinct shrinkage in the QT interval. Again, just to accommodate your eye to what a prolonged QT looks like. Here's another prolonged QT. Not so immediately evident, but you look, I don't know, can you see my arrow? Okay. So if you look at where the T wave ends, the T wave offset, you can see it a lot better in some leads. Usually we use lead 2. It's drifting really down into deep into the R to R interval. This is a prolonged QT. I mean, the first thing when you see this ECG may not be the prolonged QT, but the machine you might see other things, you know, early transition, you might see some ST segment abnormalities, but that might not be the first thing that catches your eye, unless you're thinking of it. Now, what does a normal QT look like? With a sharp T wave. By sharp T wave, I mean a T wave which ends in a distinctly visible and definable location, what we call the T wave offset. Sharp. Then this is a normal QT interval. I just want to go over, since we're all worried about ECGs, we're all worried about QTs, we're all worried about getting this information about screening patients. What do we do when we get our ECGs? What problems could sort of land in our lap once and if we decide we need an ECG on a patient? And I'll go over these one by one. The ECGs can just have a poor baseline quality. They can have low voltage and indistinct T-wave offsets. So even if you want to use an online calculator, where are you going to put your caliper if you can't really see where the T-wave ends? I mean, if your hand trembles, you can add 40 milliseconds to your calculation. Irregular rhythms where you have variable R to R intervals. I like to tease my electrophysiology colleagues and ask them sometimes, you know, half jokingly, how do you really calculate? How do you accurately calculate a QT, a corrected QT interval in atrial fibrillation when you have a great variability in the R to R interval. I don't think anybody really knows. I don't think, I mean, everybody has a recipe and a concoction, but it's in the zone and realm of recipe and concoction. I don't really know how to reliably calculate a QTC interval in atrial fibrillation. Maybe someone does. And additionally, conduction disturbances like right bundle branch block or left bundle branch block add to the QT interval without being involved in the repolarization phase of the QT of your QRS. So some electrophysiologists will subtract half the width of a bundle, either right bundle branch block or left bundle branch block, from their calculation of the QTC. So again, I don't, here's an indistinct T-wave offset. What is this QT? Who knows? Who knows where this is? Where do you put your caliper? Again, if we want ECGs and we're getting ECGs and we're requesting ECGs because we're passing some dosing threshold, whatever that dosing threshold may be, and we ask for ECG, we have to be ready to encounter this sort of thing. And as I said before, two other confounders, I put both confounders in one electrocardiogram here. Atrial fibrillation, you notice the variable R to R intervals. If you remember, the calculating scheme uses a preceding R to R interval to calculate the QTC, but what if that R to R interval is continuously changing? Which one do you want to pick? Number one. And the other part is, in this particular patient with a right bundle branch block, you have an additional prolonger of the QTC of what the machine algorithm calculates as 530, but is it really 530? I don't know what the machine is looking at here, how it comes up with 530. But if this were to land on my desk and I have a patient that's on 115 milligrams of methadone and they're using, and we need to up titrate, is this going to slow me down? I'm just positing. I'm just throwing that out. All right, I guess we're at the relevant studies and references phase here. So what I found from SAMHSA, and I did this a while back, I don't think there are any other, maybe folks can fill me in on this part, but I don't think there are any other formal SAMHSA documents that address ECGs. So what I did was look at this document and decided, rather than interpret it for you, quote them directly and just give you this little distillation. They apparently looked at cross-sectional studies, prospective, randomized trials. I don't know what kind of randomized trials they looked at. But so from SAMHSA, most OTPs are not licensed, staffed, or funded to provide cardiac screening services. Again, it's an old document, but I think it's the most recent document that's addressed this issue that we're discussing today. An optimal strategy for identifying and reducing QT-associated risk has not yet been established. I agree. Their conclusions provide only general guidance and are not intended to supplant clinical judgment. These are direct quotes. To continue, The panel recognizes that OTPs will be challenged to integrate cardiac arrhythmia risk assessment into the care of opioid-addicted patients without reducing access to vital addiction treatment services. And finally, nothing in this report is intended to create a legal standard of care for any OTP or to interfere with clinical judgment in the practice of medicine. I scanned through the literature. Again, this was maybe 6 months ago, and I found a Journal of Pain kind of methadone safety guidelines, which astonish me. Just astonishingly complicated recipes. And this was a good faith. This was a good faith effort from these folks. It's not. There was one recommendation. If you look at this, publication, one recommendation was to consider decreasing methadone dose for a QTC greater than 450 milliseconds. Again, all of these sort of guideline publications, these guideline articles, will always qualify their conclusions. And in this case, the panel identified numerous research gaps. Most recommendations were based on low quality evidence. This is what they're telling us. And no recommendations were based on high quality evidence. And yet it's still being published. And still, if you look inside the body of the report, there's a consideration of decreasing methadone for a QTC greater than 450. I mean, again, these are good faith people. So again, for your consideration, the Cochrane group, an extensive review of the literature. This is our authoritative database for systematic reviews. We should all glance at this at some point, but to boil it down, the review was to look at QTC interval screening for cardiac risk and methadone for treatment of opioid dependence. Again, boiling down their conclusions without getting into the extensive details of what they looked at. I mean, these are like statistics experts. After an extensive review of the literature, this is in 2013. I don't know of any subsequent attempts. 784 studies, cohort studies, RCT, case control studies. No study fulfilled the methodological criteria used for the review. So these reviewers concluded that it is not possible to draw any conclusions about the effectiveness of QTC screening strategies for preventing cardiac, this is a direct quote, cardiac morbidity mortality in methadone-treated opioid-dependent patients. Now, that does not necessarily disengage us from using our common sense. You know, if we see something that triggers a need for an ECG, we're not going to think of the Cochrane library and forget about doing it. But in terms of a routine approach, we should keep this in mind. And here is the big thing, which we all know, and I think you know better than I do what the mortality in untreated opioid use disorder is. Is it in the range of 1 to 3 deaths per 100 patient years? I don't know. I know it's an enormous number. One assessment, I guess indirect, best guess, look at the data. A Norwegian study from in 2009 calculated mortality where QTC prolongation couldn't be excluded was a maximum of 0.06 deaths per 100 patient years. So, I don't know how accurate this is, this first part is. I don't know how accurate the 1 to 3 deaths is, but we know one is much larger than another just from our own clinical experience. Even if these mortality rates were off by an order of magnitude, the risk of overdose and death and untreated opioid use disorder far exceeds the risk of torsade and death in the setting of methadone treatment. What the specific numbers are, I don't know. But again, this is intuitively self-evident stuff. And again, to reiterate, since not all QT prolongation leads to torsade, and not all torsade is lethal, this lopsided distribution of risk makes sense, at least to me. Again, it doesn't mean for any individual patient you forget about doing an EKG if circumstances warrant. Again, but this refers to routine reflexive requests for ECG as we're approaching certain theoretical dosing thresholds, in my opinion. I don't know how deeply to get into this, but there's an article from this group in JAMA, cardiac EP section in University of California from 2020, where they looked at what is the association of QT prolonging medications with the risk of sudden cardiac death when adjudicated by autopsy as arrhythmic or non-arrhythmic death. So it was a case-control study, 525 patients with sudden cardiac death, trying to figure out how many of those sudden cardiac deaths were sudden arrhythmic deaths, SAD, using, as many case-control studies use, 104 traumatic death controls. They assigned a QT prolonging medication score depending on their med lists, 1 low, 4 high. You can challenge their methodology. No one else that I've ever seen has developed a QT prolonging medication score. They did it. They tried. Their findings confirmed an association between QT prolonging medications and presumed sudden cardiac death. But after autopsy, that risk was specific for non-arrhythmic, but not arrhythmic causes of death. And autopsy defined sudden arrhythmic death by this group was death for which no identifiable alternative cause. CVA, tamponade, vascular rupture, pulmonary embolism, lethal toxicology, occult overdose. Any of that was found despite a comprehensive postmortem investigation using histology, toxicology, all of the tools of forensic toxicology and postmortem analysis. So it's a autopsy defined sudden arrhythmic death to distinguish from sudden cardiac death. So they did a good faith effort here. So their conclusion was that we confirmed the association of QT prolonging medications, as I said before, with a risk of presumed sudden cardiac death. but they found the risk was specific for non-arrhythmic causes. Their sense at the end of this document was that studies using consensus sudden cardiac death criteria that presume arrhythmic cause may result in confounded and or exaggerated risk of sudden arrhythmic death. I sort of copied this directly from their paper. I don't know about their grammar here. They probably needed a semicolon, someone in here, but especially antipsychotics and methadone and anti-infectives, maybe semicolon should have been here, and interventions focused solely on prevention of arrhythmic death may not fully address the risk of sudden mortality. And this was their conclusion. So let's not pop ahead here. Again, a good faith effort to look at, they didn't measure QT intervals. They used some kind of formulaic approach to assessing, giving folks a score of how many QTC prolonging drugs they were on, but it was an effort. So anyway, I guess there are no final thoughts on this. There's ongoing thoughts. Guidelines can be useful roadmaps, but we shouldn't substitute them for an integrative sense of what's going on with patients. And I think our optimal treatment strategies, they're complex. They evolve in real time and require frequent, thoughtful, individualized assessments for these patients who are vulnerable to a large constellation of health-related and social dangers. And, every patient has a unique presentation. I keep trying to get us thinking outside the boundaries of templates, never forgetting that, common sense should rule. If it's easy and to get an ECG, if you think you need an ECG, if something triggers some clinical synapse that a patient needs something, we're not saying ignore your intuitive good sense, but reflexive sort of stuttering on the edge of a dosing boundary is probably not best for our patients. And what else do I have here? Oh, okay. I guess that's it. So there we are.
Amazing.
I guess I hope I can hear everybody here. I haven't heard it.
Yeah, Dr. Zervos, can you hear me?
Yes, I can.
This was fantastic. A deep dive and really phenomenal review. I'm gonna man the chat, so I think if folks there's already a little bit of chat coming in, and I think if folks have questions, you can plop them in there. I will do my best, and I'm gonna ask the MASAM board to also help if I'm missing things. But if you're okay, we'll turn to make this interactive. And if it helps, Miguel, maybe we can stop screen sharing and we can all look at each other, unless you have more up there.
I'm afraid to push any.
No, Miguel.
Okay, should I stop? Should I stop screen sharing? I hope I.
Yeah, let's try that. If that's okay, it would be great to see folks' and I will start with Dr. Beer's comment, which came, a few minutes ago. He wrote, "We on this Zoom can help create the community standard, and there's no great reason for our definition of actionable prolongation of QTC to be 500 milliseconds. Why not mutually agree on to set the threshold higher, say 550 milliseconds as a first step?" I guess, do you have any comments on that? Yeah.
Why shouldn't we do that? Well, again, we can use whatever, whatever. It's very hard to set a QTC boundary de novo. That, I mean, folks have to get together and say, it's like exercise stress test. Everybody looks for 85% of maximum predictive heart rate. Certain numbers have been sitting in the literature for so long. And once we pass that 500 millisecond threshold, the consensus is that we start thinking torsade. Yeah, I don't think we're going to disabuse ourselves of that unless there's some kind of formal kind of meeting or convocation of electrophysiologists that say, 520 milliseconds is okay, is our new threshold. I can tell you that we often discharge patients in the 500 millisecond range from a cardiology arrhythmia service. We're not particularly worried about if someone needs to be on amiodarone or dofetilide and something hovering in the 500 millisecond area is we're not going to jump up and down and worry about it. So should I read these?
No, I'm trying to be helpful, but Michael, I don't know if Michael, you have any other thoughts or.
Yeah, I mean, basically, my takeaway from every preceding comment of yours was there's a very loose, at best, if any, connection between methadone and arrhythmic death, QTC and arrhythmic death. Arrhythmic death is a rare event, and for us to be interposing this QTC between a patient and life-saving medication seems, I feel like we need to challenge it at base until that time comes. We're the community standard, and we can say, well, not 500 anymore, 530, 540, 550. I mean, we will be saving lives by doing that. There will be bad events.
I absolutely agree with that. You cannot say this patient is at 500 milliseconds. They're actively using. I'm not going to up titrate methadone. I mean, if you look again at the relative risk, I mean, it's like a mountain and a little hill of sand. So I absolutely agree with your assessment. But, again, everyone needs an individualized assessment. I wish we could just chisel this into granite so that treatment is not delayed or impeded by theoretical issues. But I think that's not going to be easy to do. There are too many opinions on this, too many medical legal concerns, and I think every clinician has to sort of resort to their own native clinical intuitive sense of what's right for a particular patient that's sitting in front of them.
Thank you, guys. I'm going to turn us to Dr. Poti. Had a question on calculations. I don't know if you want to unmute. And then there were some other folks who sort of jumped off that with more specific questions.
Yeah, hi, Jerry. That was great. Thank you. There's a lot of different formulas to calculate QT, and the one that I understand most of the standard ECG machines use is one of the more conservative ones, the Bazzett's formula. So I'm just asking, I mean, we play a game where we recalculate with the different formula and the number changes by quite a bit each time. I mean, like, I know we're playing a game, we're trying to document so that there's a little bit of our cover your ass when you work in an OTP. I'm just curious what formula you like the best.
Just the Bizet. I don't think, I mean, I haven't seen a huge difference. I haven't used the other formulas. I understand the need to get around a number that is sort of chucked out at you by an algorithm. But, that algorithm, I am more worried about the quality of the data that goes into the calculation rather than the calculating mechanism. You can use any number of QTC calculation formulas, but what is the machine algorithm looking at? Does it have a sloppy T-wave offset? Are there some irregularities? Is there a bundle branch block? Is there something in the intrinsic data that overwhelms any thought of using a different formula? That's my worry.
I think Emily Herstack, I don't know if you want to jump on, shared that worry and sort of how you adjust the calculations in the setting of a bundle.
How do I do that? Or
Emily, I don't know if you're. I don't know if it was just a comment on.
bundle
Yeah,
branch
sorry, I'm
block
in
will give you.
transit. It was really just figuring out. I've seen a lot of calculations online when you're in the setting of a bundle branch block, which again, as Ruth said, like give you totally variable numbers depending on which one you choose to use. And I don't know if you have an approach that you'd like to share with us as a cardiologist.
How do I factor in the bundle?
Exactly.
I guess, again, many electrophysiologists that I will ambush on the arrhythmia for advice will tell me to subtract half the width of the QRS in a bundle. So if you measure the total milliseconds, calculate your calculate your QTC, and subtract half of the bundle, so to speak. So, because you will not invariably, but you will often get an artificially prolonged QT interval with bundle branch block, because you have that huge fat slice of QRS that's not really part of the repolarization phenomenon. It doesn't give you a susceptible zone of early after depolarizations where electrical mischief can occur.
Thank you.
You bet.
There's now a couple of questions. I know we have about 10-15 minutes left. There are a couple of questions on sort of using portable EKGs for QTC monitoring in methadone patients, so that the Cardia Mobile, if you've had any experience using that, or personal smartphones be reliably used. So I don't know if you have any thoughts on sort of.
I don't know whether those devices are FDA approved to measure QT intervals. I think you can see the QT interval. I don't know whether it's legitimate to use. I mean, I suppose you can use it to document anything you want. I mean, in this zone where we're trying to justify treatment, we're trying to get around this QTC issue in some meaningful but safe way. I suppose you could look at the QT interval on one of these devices, but I'm not sure. I don't use them. I don't know whether they're FDA approved for measuring QT interval. They may have been recently. That's not something I've looked into recently. It is an excellent idea. It would be very interesting if we could just put our fingers on a device and get something that might let us up to, you know, in a meaningful and safe way, up titrate medication, because we have some concrete objective evidence that this QT is X, or that this QT interval looks okay, or that it's probably 480, or that it's probably 470. But I don't know. That is an excellent question. I will look into that. Okay, there it is.
Thank you. Justin Burke, did that answer your question, or do you want to pop off and?
Yeah, no, very, very helpful. Thank you. It's something we've been trying to mess with, but I don't know that it's, very helpful. Thank you.
I'm going to keep going in the chat. There's a
But,
lot
you
of.
know, then again, let me just say that our ECG machines are also certified to calculate QTCs, and I have to refer you back to the potential technical confounders in a, you know, $20,000 ECG machine. To what extent those apply to these little devices, I'm sure the same potential technical impediments have to be considered. But it's an excellent and interesting idea if you want to move things along in your office.
Thank you. Dr. Cushman, do you want to talk about documentation and counseling? I think you had a comment on that.
Oh, and I don't really, it was just a comment. I just think that there is so much unknown, but that our patients, like, you know, we definitely do, of course, you know, have patients who have known structural heart disease, even family history of sudden cardiac death. And that when I just think it's an important point for us to counsel the patient about what we do and don't know. It's not an easy conversation, because explaining what a QT interval is to a person who might not have a very high educational level is not easy unto itself. But explaining that, you know, these are the concerns, we understand, you know, explain that you agree that the dose increase is absolutely warranted. And actually patients I've had, they understand that. They'll say, oh, I'm more likely to drop dead of fentanyl than to drop dead of a heart problem. So.
Exactly. That sort of moves into the shared decision-making zone.
Yeah. Right. Steve Jones, where are you? Steve wanted to bring up some of the legislation and how this sort of may impact MODA. Do you want to ask your question or stop?
Sure. The Congress is presently considering MODA, which would expand the ability of to prescribe methadone for opioid use disorder to addiction specialists who don't have to be in an OTP. And that's, to me, seems like a great idea when you have fentanyl. And I'm just wondering if you think the QT intervals are in any way relevant to that decision.
I'm not sure. I would have to think about that. This legislation is actively considered, about to be passed? I mean,
It's been approved by the Health Committee in the Senate, and it's under consideration, and ASAM has been suggesting that people should contact their representatives and senators in the US Congress to ask them to co-sponsor it. So it's under consideration, I think is the right way to describe it.
and your specific question is?
Does expansion of the ability to prescribe methadone to treat opioid use disorder to outside of OTPs, is there a relevance of looking at the QT interval in that situation?
Oh, oh my God. That's going to open a floodgate of questions. I mean, if that happens, well, I'll tell you, if that happens, we will have we'll have a flood of empirical data, I guess, from other sources, because we'll have a lot more people in methadone treatment. We will have a lot more background information about unexplained sudden cardiac death, which again, an arrhythmic death is always a death that's it's defined by inability to be attributed to anything else. It's a definition by exclusion. That that will give us, I think, open up the floodgates of the so-called sudden arrhythmic death scenario. Should I look at these little tags here and say?
Sorry, I'm trying to scan them. I'm gonna jump to a sort of a clinical conundrum that a lot of folks face, which is Audra Williams, I don't know if you're on or you want me to share.
I'm here. Can you hear me?
Yeah, do you want to share your question?
Sure. So just thinking through when we do have those patients that still have a persistent EKG, QTC greater than 550. So obviously correcting everything else, but sometimes it persists. We can't exactly figure out why. And we get faced with cardiologists often saying, to stop the dose. A patient might be, wanting to continue or not. And I think we always get stuck in the middle of trying to say that, this is an overall low risk, but could holding the dose, could decreasing the dose temporarily help? What about splitting the dose? Is this a patient that we should talk about a bupe transition? Curious to hear your thoughts.
Yeah, I can only address what I would do. I have a much higher threshold. I've developed it. Again, living at this intersection between addiction medicine and cardiology, I have a much higher threshold of QTC that I'm comfortable with. But I can't sort of transplant that comfort to other settings and, to clinicians who are not trained cardiologists. Whatever you say, the minute you see a QTC of 540, you're going to be stopped in your tracks.
Sorry, I'm on a call.
So again, my level of comfort, it isn't generalizable. I mean, if there was some kind of consortium of big thinkers that could get together and give us some, perhaps SAMHSA, give us some guidelines that it is not exactly some kind of expert consensus that these zones, 520, 530, are within some framework of reasonable methadone dosing management. Then that takes the onus off of non-cardiologists, off of internists. It takes, because again, my comfort is not necessarily translatable, and to offer a template that it's okay to do this. That in a way is almost as rigid and formulaic as saying that you need to get an EKG at dosing at 120 milligrams of methadone. I mean, there's a duality there, but an expert consensus, I think, ultimately is the way to go from SAMHSA.
So can I ask, is there any threshold that you would say is, I know there's no data, so this is where it gets so hard, but is there any threshold number where you would say, nope, we got to hold the methadone because it's 600 or something like this?
You mean a real non-distorted, actual true QTC?
Oh, that's a great question.
I mean, I've seen EKGs come with the algorithm, the machine algorithm reading 600.
Yeah.
If someone is actively injecting, actively using, I mean, I start thinking at 540, a real 540. I don't see it often. Once you get into a clearly documented area of multiple ECGs, 520, 530, 540, you start thinking. But I think it depends on the patient. Do they have symptoms? At that point, how important is it to get them to see a cardiologist? But what is that cardiologist really going to tell you? Oh, it's okay. Their instinct, if you get a cardiology consult, is probably going to tell you to reduce their methadone. So we're in a complete no man's. We're in an unknown zone where the danger of torsade and death is very hard to document, very hard to quantify, and where the danger of overdose and death is not hard to quantify. So you have these two, you have these two risks with an overwhelming risk from overdose and death. So
Absolutely.
what do I do? I mean, in the context of an order, if you're going to increase that patient's methadone, I would include, in this particular circumstance, we acknowledge that the QTC interval is X, but that given that the risk of overdose and death far exceeds any potential risk of arrhythmic death from torsade, we will continue to up-titrate methadone. That's why I say pull that reasoning, that rationale into the context of an individual order, rather than just I'm going to increase this patient's methadone dose. And somewhere in my note, I will make mention. What I do is I pull that into the order.
That's great.
Thank
Dr.
you.
Zervos, thank you so much. I'm realizing we have 1 minute left, so I'm just going to wrap us up. I think, that speaks to some of the other comments that we didn't get to, which is thinking about the adulterated drug supply, right, which could certainly impact, and as well as cocaine and other things that impact, right, the QT. So we all, I think, here deeply appreciate your time and expertise and wisdom that you've collected. A couple of announcements. If folks are sort of still interested in this topic, reach out to the board, and we're happy to continue to think how we can push forward in advocacy on this. We have upcoming reminders of our next 2 presentations. We have this presentation will be posted on our YouTube channel, so we hope you join. And thank you all for your early morning time with us. This was a great session, and I appreciate all the wisdom.
Time for some coffee now.
Yes. Thank you. Good to see everyone.
All right. Thank you.
Take care all.